name is Lisa Cheek. I'm a doctor of physical therapy, and educating is a huge passion of mine. So a brief introduction into my background. I have worked in pelvic health my entire career. I cut my teeth in the pelvic PT world in Denver, Colorado at a specialty pelvic health clinic. So we did only pelvic health for patients of all genders, all ages, had a fantastic mentorship program. So I really was so fortunate to learn from the best. And we also shared a space and got to work alongside a urology practice that did only pelvic pain. So as a, little baby PT, I really did get to learn from the best. And I was fortunate enough to be able to come here, which actually is my home. I'm from Santa Fe, New Mexico, and I was fortunate to be able to come home and, share my passion and what I've learned with my home. So, but I every day I'm just so grateful for all the lessons I've learned, all the great mentors that I've had, but really the best teachers that I've had and continue to have every single day are my patients. I learn so much every single day because every body and every situation, every pregnancy, every birth is so different. And you all have so much to teach me. And if I ever stop learning from you, then that's the time that it's time to find another field. So I worked with pregnancy, prenatal, postpartum in the beginning of my career, and I felt fairly competent in that. But until I experienced it myself, I really lacked that important perspective. So I will tell you, I myself had a pretty difficult pregnancy, a difficult labor and delivery, a very difficult postpartum period, which I would say 2.5 years later is still going on. And so it's been really the most valuable lesson to me to really understand what it means to recover from birth, if one ever truly does so, but really what it means to live in your body as a mother, and what that means to really learn about the new demands that motherhood brings to your body. These are the topics I can cover. So the pelvic floor, we can get super in depth about the anatomy, the function of our pelvic floor, and our core, our abdominal wall, which is obviously extremely important in the context of pregnancy, delivery, and postpartum recovery. We can talk about bladder, bowel, and in the context of pelvic organ prolapse and what we do to prevent it and what we do in recovering from pelvic organ prolapse. We can talk about pain. What is pain? What's normal? What's not normal in the context of pregnancy and recovery, and getting back to exercise. So let's talk about our pelvis first, okay? Let's get right into some anatomy. So the pelvis is a bony ring, and pelvis lives at the bottom of our spine, okay? It's a ring that's comprised of 2 large bones. Those large bones, fun fact, are actually 3 separate bones. So those little babes in your bellies right now, those bones are actually all separate. And as they grow, sometime in the first few years, those bones actually come together and form that big solid bone that you see right there. And so as adults, that's one big solid bone. And that ring is held together by the sacrum and then the 2 hip bones on the side. And then the 3 joints that hold that ring together are going to be the 2 sacroiliac joints and the pubic symphysis. Now, those 3 joints usually do not move. They're usually really stiff, really stable, and they're held together by ligaments that are really, really strong, really, 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 really stiff, okay? Enter pregnancy. And in the 12th week of pregnancy, your body starts producing hormones that peak in the 12th week, namely relaxin. Relaxin does exactly what it says it's going to do. It relaxes everything okay? All of your connective tissues. The main objective there is to relax those really stiff, stable ligaments in the ring of the pelvis so that eventually a little head and shoulders can pass through there, right? So in the context of, opening up the pelvis too much, occasionally we have, well, not occasionally, in fact, many women will experience something called pelvic girdle pain. Either at the pubic symphysis or one or both of the sacroiliac joints or some combination of any of those, where they'll experience excessive motion, excessive tension through those joints because of the relaxin. You're in the joints, in every joint in your body, there are nerves within that joint that tell your brain where your body is in space. Well, fun fact, your brain didn't get the memo all the way that you're pregnant and that this is a good thing, right? All it hears is, oh my gosh, my pelvis is falling apart. And so it reacts very strongly. We'll get to, sort of the pain response, but basically when those joints start to melt and become excessively mobile, your brain can interpret that as an injury, right? And so that's where we get pelvic girdle pain. And so there are sort of, to answer your question right off the bat, if we are experiencing pain at the pubic symphysis, the sacroiliac joints, there are some general kind of rules that you would want to follow. We want to sort of avoid those big asymmetric motions like getting in and out of a car, swinging your leg, very big wide motion side to side, rolling in bed, anything that's going to cause the two halves of your pelvis to move in a really asymmetric way. So you have to be really careful with body mechanics if you are experiencing pain already. Now, not everybody gets this separation, this pelvic girdle pain. I work with pregnant patients every day who don't have that laxity or who aren't experiencing that pain. So, it's very individual. Should you preemptively be cautious and avoid, super asymmetric poses, warrior pose in yoga, things like that? Maybe, if you want to err on the side of caution. But that's up for debate, really. If that means cutting down on your physical activity and becoming more sedentary, then you really have to weigh the risks and benefits there. So is it a question of modifying your activity to avoid pain versus cutting back on your activity to avoid the risk of pain? Does that make sense? And we can talk more about kind of your individual situation kind of at the end. But that's the pelvic girdle and one of the big effects of pregnancy. But just in general, the pelvis is a really important attachment point for a ton of muscles. All of the muscles that hold up your spine, your entire abdominal wall, all the deep hip rotators, all the muscles that move your hip in and out, your hip adductors that move your leg in towards the midline, your abductors that move your hip out. So pretty much everything from here down is directly connected, okay? Super, super important. And then not to mention the star of the show, your pelvic floor. So pelvic floor is going to span the entire bottom part of the pelvic opening, okay? So it's going to go from pubic bone to the coccyx, the very tippy tip of the spine, and then all the way out to your sits bones side to side. So we think of it as forming a sling or a hammock in the base of the pelvis. I can get real nitty-gritty about the anatomy. You guys want to learn about the 3 layers of the pelvic floor? We can go there. I'd love to go there if you want to go there. So, and you don't need to remember all this. I'm not going to quiz you, but I think it's fun to know. It's a super complicated anatomy, and it's really fun if you're a nerd like me. So, first layer, we call this the urogenital triangle, okay? So these are the muscles that surround the opening to the vagina They support the perineum. So you can infer right away how important this group of muscles is going to be for childbirth. The perineum is a really stiff, stable, muscular junction. It's got some tendon, it's got some really stiff connective tissue in there because normally it plays a really big support role in the bottom of the pelvis. Now during childbirth, perineum has to stretch and relax quite a bit. And if we're going to have any tearing in the perineum, then or in any of this area, the perineum is usually what takes the brunt of the force. Tearing can happen anywhere, but really the perineum is the stiffest structure, and so that's the one that usually is going to give more than anything else, okay? We also have the bulbocavernosus, which is sort of like the sphincter muscle to the vaginal entrance, and then we've got ischiocavernosus, which is a really important muscle with regards to sexual functioning, okay? Second layer, these are going to be the muscles that are really important when we talk about continence of urine. So here's the urethra, just right next door to the vaginal entrance. And the urethra is the pathway from the bladder to the outside world. So we've got some muscles that sort of lasso around the urethra. They create what we call forced closure around the urethra. They hold it closed till it's time to go. They also talk to the bladder and they give it signals about when's the right time to go and when's not the right time to go, okay? And we'll talk about that more in depth later, but it's a really important feedback loop between these two, okay? Then the third layer is the really big layer of muscles, the levator ani, okay? This is what most people think of when they think of the pelvic floor. These are the big, broad muscles that play the big support function for the organs. They play a really big role in continence of our bowel movements. We'll talk about bowel in just a little bit. And they play a really big role in breathing too. They actually work opposite the diaphragm to help draw air in and push air out. So if and when your pelvic floor therapist has you doing funny breathing exercises, that is why, is because using your diaphragm is a really great way to start connecting with your pelvic floor. And we'll get into that in just a little bit. So those are the three layers of your pelvic floor. Now to touch on your question about back pain, the pelvic floor is part of a system of 4 muscles, okay? And we talk about it in my world, in terms of the pelvic core or like a canister, okay? So we've got 4 walls of this canister. Pelvic floor on the bottom, diaphragm on the top, transverse abdominis, which is the deepest layer of your abdominal wall. It's sort of like a corset muscle or a weight belt that wraps around the middle. And then you've got some little muscles going up your spine called the multifidi. So if the transverse abdominis is your corset, the multifidi are the strings to the corset. They pull it tight, okay? So keep that image in your mind. We're going to talk about we're going to come back to this when we talk about the core. But you can see right away how if any piece of this is not functioning properly, it's going to put strain on the spine, okay? So there's some research out there, and there are some voices out there in the rehab community that say that diastasis recti is not a cause of back pain. It's only a cosmetic issue. I just like to point out that those voices are overwhelmingly male. So, just saying. So, next, let's talk about the layers of the abdominal wall. So you all know that the layers of your abdominal wall are currently being stretched to their structural limits. But the beauty is that they're made to do that, and they have some really cool features that allow them to do that. If they weren't meant to stretch and grow, then it would just be one solid sheet of muscle. But you notice they have all these little lines and little sheets of connective tissue that allow them to grow and stretch. So our first layer are external obliques. These are the muscles that help us twist. Actually, no, our first layers are rectus abdominis and our external obliques. Rectus abdominis is our six-pack muscle, which we'll talk about in a little bit. Its function is to curl your trunk forward, okay? And that attaches to the external obliques. But notice all these little lines of fascia that are made to grow and expand. Underneath the external obliques, we have the internal obliques. Those muscles also help you twist. The obliques, when they're working together, also help flex your trunk. And then underneath, we have the transverse abdominis, our corset muscle. Transverse abdominis turns into fascia or connective tissue and then attaches to your spine. I really love looking at the abdominal wall from this angle too. This is a cross section of the abdominal wall. This is your spine right here. And you can see how your abdominal wall really is like a corset around your midsection. Here you can see those little sheets of connective tissue that are meant to grow with your abdomen. And they stretch and they grow. And this is not just with pregnant women. I mean, you know, they're for any human being who gains weight in the abdomen. That's what they're there for. But then we also have these beautiful 3 layers that are protecting our organs, our spine. I mean, it blows my mind how well this is designed. So, diastasis recti is part of our anatomy. And there's a lot of talk about preventing diastasis recti. I want you to get that out of your head because at 36 weeks of pregnancy, 100% of women will have some degree of diastasis recti. You have to, otherwise your belly would split in half, okay? You absolutely must, your six-pack muscle must separate. That line is called the linea alba, and she's made to spread apart, okay? And after birth, some 60% of women, their diastasis is going to go back to normal with no intervention at all. Now, the other 30 whose diastasis persists after that 6 to 8 week period, it's really up for debate why that stays open in some people and not in others. I tend to think, with my experience, a lot of it is genetic. I think sometimes it's just how your connective tissue is. Some people are just really loosey-goosey in their connective tissue. I will tell you, I have horrendous loose connective tissue. I'm hypermobile, super bendy. I had a C-section. I did nothing for my core postpartum, and mine went shoop with no intervention whatsoever. Okay, so, you know, I'm just one of those lucky 60%ers who did nothing, and I have seen women who have done everything and it still remained. So sometimes there's just not rhyme or reason as to why someone stays a little separated and why somebody's doesn't. Sometimes some people just get lucky. So postpartum, anything 2 fingers width or less is considered normal, okay? Men can have diastasis too. I see it in men a lot, particularly men who lift weights, do a lot of core work. It happens. It's just kind of part of life. The connective tissue, the linea alba, isn't torn. It's just spread. It's just overstretched, okay? If it is torn, that's something called an umbilical hernia, and that's something that needs to be repaired surgically. A diastasis, most times, unless it's very, very large, 4 fingers or more, typically can be rehabbed conservatively, okay? So some people will have different patterns of separation, those whose diastasis persists, and that just depends a lot on your own anatomy, how baby sat in your belly, and, you know, just various factors. So many people will have it just right around the belly button. Some people have it below, some people have it above, and some people have it below and above, okay? So there is no preventing diastasis. It's not a bad thing. It's a good thing, okay? The problem with diastasis comes when we talk about that core, that system of muscles here, okay? Now, typically, this is where I tell you all to get down on your backs and test yourself. I'm not going to do that with you guys. That would be just wrong. But how we test in the clinic, I would have my patient lay on her back, put 3 fingers in her belly button, and do a little crunch, okay? And if your fingers can sink in to the belly button, that means there's a little separation there, okay? So in my world, we measure in terms of finger width, how many fingers can I get in that little separation, and the depth. It's a pretty quick and dirty measurement. It's not, it's an estimate, okay? And it's never so much for me about the actual separation. It's more what happens to that separation when you are moving, when you are lifting, when you are having a bowel movement. Basically, I'm looking to see, are you putting pressure into that separation? When you're moving, does a little dome pop up? Does a little tent pop out of that separation? You can have a 3-finger width separation in your rectus and not have any problems. But if when you're moving, a little boop, a little dome pops out, that means that you are not regulating pressure well. Pressure is getting pushed into that little defect in your abdominal wall, and that's going to throw off that whole core muscle system, okay? This is another view of that core that we were looking at earlier, and this one's moving, okay? So I love this diagram. I show it to most of my patients. So what's happening here, we're looking at the pelvic core as you are inhaling and exhaling. So anyone have a guess as to which one's an inhale and which one's an exhale? Belly going out, belly going in, pelvic floor dropping, pelvic floor lifting.
Lift on the exhale.
Yeah, good job. So as we inhale, if we are using our diaphragm and our pelvic floor correctly, our belly expands, makes room for air. Our pelvic floor drops, gets really soft and open. As we exhale, our pelvic floor lifts, our abdomen corsets inward to push air out. Sounds great in theory, really difficult in practice. Those of you who've got babes in your bellies, I know there are messages out there that you cannot do core work when you are pregnant. Not true. You absolutely can and should. But you must master this first. It's tough to use your diaphragm when pregnant because there's a little body next to it. However, once you can master the diaphragmatic breath and the activation of your core muscles, everything becomes a core exercise. Singers are usually some of my best patients because they're like, oh, I know how to do this already. I will tell you, and this is nothing against the Pilates community, but Pilates folks are some of my most difficult patients because a lot of the cueing in Pilates is directly opposed. So a lot of it, and some forms of yoga as well, will have tension on the inhale and relax on the exhale. And so it's not wrong, none of it is wrong, but when we are learning to properly use our core in the context of pelvic rehab and just how our bodies are physiologically designed to breathe, it's just backwards. Go home, take a peek at your baby's breathing. It's all in their little bellies. Okay? Use them as your inspiration for belly breathing. They haven't learned how to chest breathe yet. That's a stress thing that we do as adults. So, on that note, so when we have that diastasis, that represents a defect in that core system. So our body needs pressure. That core, its job is to direct pressure inward in our abdominal cavity. So think about like weightlifters, right? They put on weight belts when they're going to lift something big and heavy, right? And what are they doing? They're adding pressure to the system, right? Because your spine needs pressure. Your spine likes pressure, right? So if all 4 of those muscles are working correctly, pressure is going inward, okay? When I'm doing my exercises, I literally imagine a little white light right behind my belly button, okay? With every exhale, every drawing inward, okay? Everybody has a visual that works best for them, but that's just where my mind goes, okay? So say we have a little diastasis and we see that little dome, that means that that pressure is going boop, outwards. In another scenario, say we're lifting something and we notice a little leakage of urine or a little incontinence of gas, okay? That means that that pressure now is not going inward, it's going downward, okay? That means that the bottom part of our pressure system is now not doing its job. Does that make sense? So that's where learning how to breathe with your diaphragm and activate your core properly is everything. So it's never what you do, it's how you do it. And if you can learn that very simple motion of the belly pump, it's what it's called, or has been called by certain exercise systems, then you're good. Everything will fall into place after that. So if anyone wants to stand up, we can take a quick little diaphragmatic breathing break. So hands on rib cage. And let's take a big breath in and out. And what I want you to feel in your lower rib cage is those lower ribs kind of chicken winging outwards. They should be going whoop out to the side as you breathe in and in towards your midline. Now, in a non-pregnant belly, keep going at your own pace. I would focus more on my abdomen. I would focus on my abdomen getting really soft and really slack. But if I had a little human with a foot in my diaphragm, I would focus more on that 360-degree expansion of my rib cage. Now bring a little bit of awareness now into your pelvic floor. And just think about the sphincters in your pelvic floor. And on that inhale, imagine that sphincter gets so open that literally you could just let out a little fart. In one of the courses I took, Michelle Lyons, the great pelvic PT, just a giant in my world, told a bunch of non-pelvic PTs to let your pelvic floor get so soft you could just lay an egg. And when it comes to the labor and delivery education that I do in my clinic, this is an essential skill, is learning how to consciously open all the sphincters in the pelvis. Remember that bulbocavernosus muscle we just learned about? You got to learn how to do that with her too. Good. And now that we've got the inhale down, let's focus on the exhale. So on the exhale, breathe out a little more strongly than you were before. And feel those abdominal muscles kind of corset in towards the midline. Belly button's going to come up and in towards your midline. It's probably going to startle the heck out of your baby. Be like, ma'am, excuse me. And those muscles might feel pretty weird if you haven't engaged them in a while. But it's perfectly safe to hug around your baby with your transverse abdominis. So she asked about the connection between opening up the pelvic floor and opening up the throat while singing. And in the context of labor and delivery education, when we're learning how to open the pelvic floor, lengthen the perineum, and push through the abdominals, vocalizing is huge, right? And one of the big things that we hear in the delivery room a lot is to hold your breath, purple push, and closing your throat. While it can generate a lot of pressure in your belly, it also causes your sphincter in your pelvic floor to go. So my labor and delivery nurses were not happy with me. So how does that feel to kind of hug around the baby with your abdominal muscles? Kind of weird at first, right? But it can feel really comforting too, to actually have that little natural belly band almost. And that's what it's there for. You can actually relieve so much pressure in your own belly just by activating your own corset, your own weight belt. Good. All right. And if you can master that one skill, then really you can never learn how, or you will never need to do another core exercise in your life. So let's talk about some normal anatomic changes that happen during pregnancy. So we talked about the effect of relaxin. Relaxin's levels in your bloodstream peak around week 12. So that's good news, right? It doesn't mean that your ligaments are just going to get looser and looser and looser, right? Otherwise you just like turn into a puddle on the floor. What happens though is that your body mechanics change, your structure changes. So we have weight on the front of the body that your body is not used to. And what happens as the uterus comes up out of the pelvis, your center of gravity is going to shift, right? And it's going to come up and out, okay? And that's not only happening in your belly, but also in your breasts, okay? And so that's going to change, number one, the curvature of your spine. And so our spine is normally in a pretty little S curve to help support the weight of our head, the weight of our upper body. But because of that shift in the center of gravity, it's going to be pulled even more forward, okay? Which is necessarily going to put a lot of stress and strain on the point where the lumbar spine and the sacrum come together. So those vertebrae that are coming together are going to what we call shear on one another. They're going to slide. And so little aches and pains in your low back are normal. That doesn't mean you have to just put up with them, but there is a structural reason for them, okay? The change in the curvature is also going to happen in your upper back because of the weight of the breasts. And so we might notice our shoulders getting more rounded. Also the curve of our lower neck getting more pronounced, okay? We tend to collapse into our front body in our upper chest, okay? And that does not get better once baby comes, because then we spend the next however long holding baby, nursing. And so we have to be really conscious of not just living in our front body. We got a back body too. The other thing that happens is that the muscles on the back of our body, what we call in my world the posterior chain, your back muscles, your glutes, your hamstrings, your calves, they are working 24/7 while you are upright to keep you from literally falling on your face. Because your body, your mechanics, they are not used to this weight. So you would literally tip over without your calves, hamstrings, glutes, back muscles. So myofascial pain during pregnancy is so common. Trigger points, referred pain. When I see, the most common referral I get for PT during pregnancy is for pain. Hip pain, back pain, that type of thing. And sometimes it's true pelvic girdle pain, that laxity in the bones of the pelvis, but more often than not, it's just myofascial pain, knots in the muscle. So these are things that can be easily self-treated at home with a tennis ball, a Theracane. They sell them at Taus Herb, by the way. It's the only place I've ever seen them sold retail. They are my all-time favorite myofascial tool. Or, if you have a good myofascial therapist who is good at treating trigger points in the muscle. Trigger points are caused from overuse, and those muscles are being overused to no end. So hip rotators, low back, hamstrings, outer hips, those are really the prime areas that get overused, not to mention upper traps. Chest muscles. So myofascial pain is something that I see a ton of, okay? To the issue of groin pain, we can go ahead and address that now. We've got the ligaments that hold our uterus forward. Actually, I think I had that on the next slide. Yeah. So normally, in the non-pregnant pelvis, the uterus is tipped forward, and we've got ligaments that hold it forward. The round ligament is the big one, but there are other ligaments in there too. Round ligament connects to the front of the pubic bone. So when the uterus starts to grow and tip backwards, round ligament gets stretched to its absolute max. And so there's the classic round ligament pain when you move too quickly and that ligament gets whipped into extension or into tension. And we've probably all felt that at one time or another, that oh my gosh, what just happened kind of pain. But then there's just, the ligamentous tension that can happen in that region. The other thing that I am learning more and more about every day is the connection between some of the nerves that come out of the spine and the groin area. You've got two big spinal nerves that come out of the lumbar spine that travel right along the inguinal ligament. They provide sensation to the pubic bone region. And think about how much this area basically is getting compressed. So if we're having any back issues or ligamentous tension in here, those nerves are going to be affected. So there are numerous pain generators in this area, from the hip joint to the ligaments to the myofascia to the pelvic girdle itself. So it's very, very complex. I think the myofascia is the easiest place to start. Doing some good trigger point release to the muscles in that region. And if that doesn't cut it, then it's time to, seek professional help. Does that make sense? This area is so complex in terms of pain.
And it could be combination.
Absolutely. And anything that was pre-existing is likely going to be amplified during pregnancy because of our friend relaxin and these anatomic changes. So let's go back real quick. Posture itself is not a cause of pain. However, it is worthwhile to think about some of the ways our body compensates for these changes. So there's a posture called hanging on your ligaments, where basically your body's going to subconsciously or unconsciously throw your hips forward, and it'll do that when you're pregnant. It also will do it when you're holding a baby. We've all done it. I catch myself doing it all the time. And what it's doing, you're basically winding up the ligaments. Oh, hey there. You're winding up the ligaments in your hips. So your body is holding this load without actually using any muscles. It's turning your glutes off, okay? And that's your body's compensation for basically not having the strength to hold up the load. Okay, so if you catch yourself in that posture, it's worthwhile to unlock your knees, reset the curvature of your spine, try to neutralize your posture, and find these areas where you are locking out. Anytime that you are locking out, that is your body basically trying to do more with less. Okay, posture itself is not a cause of pain, but it's more your body trying to cheat for weakness. And so, it's worth looking at and then thinking about, okay, what is my body trying to tell me about where I need to strengthen? Does that make sense? I really hate this myth that bad posture causes you pain. It does not. It's your body chooses function over form any day of the week. So, and then the last anatomic change that I'd like to address is pressure in the pelvis. Y'all know about this very well. Uterus, part of its support structure is that it's literally right on top of the bladder. So, when we're talking about pressure on the bladder, in the last weeks of pregnancy, it is absolutely normal to have urgency, frequency, occasional stress urinary incontinence. It's just a pressure thing. It's a real estate thing. Don't freak out, okay? If it's happening all the time, if it's like every time you sneeze, if it was happening early in pregnancy, if it was happening before pregnancy, that's when it's time to really start to say, okay, maybe this isn't normal. The occasional little leak here and there, yeah, it happens. Look at what's going on in there, right? But really, really frequent stress urinary incontinence, not normal at any point, okay? So, on to the bladder, and I'll go through these ones kind of quickly. But in a normal bladder, the pelvic floor and the bladder muscle are talking to each other all the time. And so the pelvic floor muscles remain closed as the bladder fills. The bladder will have two urges, a first urge and a second urge, based on how full it is. First urge you can ignore, second urge not so much, okay? And when you go and sit down to use the bathroom, pelvic floor, well, your brain sends the signal to your pelvic floor that it's go time. Pelvic floor lets go, bladder squeezes. And that's how you go to the bathroom. And then when it's done, pelvic floor squeezes, bladder lets go. So it's this real like push-pull kind of mechanism, right? Now during pregnancy, that feedback loop gets real messed up because you don't have the room. You don't have the capacity for the first urge, the second urge. Your bladder capacity goes way down just due to real estate. So your urgency, frequency is going to be different. However, it is still worthwhile to practice mindfulness surrounding your bladder habits. And we'll talk about that in a second. So signs of bladder dysfunction, we talked about stress incontinence, and that's a sign of poor regulation of pressure in your abdomen. That pressure system is not working, the bottom half is not pushing up, and pressure is being forced downwards in the system. So that would be leaking urine with coughing, jumping, sneezing, laughing, stuff like that. Urge incontinence, on the other hand, is like the can't make it to the bathroom in time. You get the warning, but then on the way to the restroom, you're leaking, okay? Most people who come to me with incontinence issues have elements of both. I rarely see just pure urge or pure stress. Most people have elements of the two. Even if you're not leaking yet, urgency and frequency are signs of incontinence or signs of urinary dysfunction, and getting up to the bathroom in the non-pregnant person, 0 to 1 time a night is considered normal. Over the age of 65, your bladder loses elasticity, so 1 to 2 times is considered normal. There's also hormonal factors postmenopausally that affect that. But in general, your bladder shouldn't be doing much at night. So again, that all kind of goes out the window when you're pregnant. However, if you take nothing else from this talk, it is never normal to pee your pants. Again, it is, for the folks on Zoom, it is never normal to pee your pants. Urinary incontinence is common. There is a high prevalence of it. That does not mean that it is a normal consequence of having children. It is not a normal consequence of aging. It is not like your hair going gray. It is not just something you need to expect, not something you need to deal with, okay? It is always a sign that there is some dysfunction going on, okay? I know our mothers didn't have the resources available to them to address these issues, and so they normalized it, okay? It's not their fault, but our mothers, our grandmothers really, normalized this idea that, oh, you're just gonna pee your pants after you have babies. Common, not normal, okay? Not a natural consequence of having babies, okay? Having a little bit of leakage in the early postpartum period, yeah, you might have some issues there because it takes a good 6 to 8 weeks for, for the swelling to go down, for some of the structural issues to resolve themselves. But if that stuff persists, then that's when we know there's dysfunction going on. This is another soapbox of mine. I won't spend too much time here. 4 things we need to stop right now for our bladders. Going to the bathroom just in case. These trips that, maybe there won't be a bathroom. Yeah, we have to do it sometimes, but we don't want our bladders to get in the habit of not filling all the way because that interrupts that feedback loop. Hovering. Women, can we all just make a pact that we're not going to hover? Because if we all don't hover, then we won't have to hover, okay? Basically, the point of that one is that hovering is going to activate your pelvic floor muscles and your pelvic floor can't relax. And that messes with that feedback loop, right? Your pelvic floor needs to relax. And if the pelvic floor does not relax when you're peeing, then your bladder will stop listening to it, okay? Dehydrating to avoid having to go or leaking. That can actually make incontinence worse. Concentrated urine is acidic. Bladder doesn't like acidity, and so it's going to try to flush it out. In the literature, fluid intake under 50 ounces a day is associated with increased urinary incontinence. And waiting too long to go, that is something that us healthcare professionals are very, very bad about, but you can actually give yourself an areflexive bladder doing that too. So really the first step that I think everybody can benefit is mindfulness surrounding our bladder, okay? Even in the pregnancy period when all bets are off, there's very little real estate in our pelvis for our bladder, our capacity is all wonky, and we have just crazy amounts of pressure. Let's all still try to be mindful about our bladder. And when we are getting urgency, let's stop and think, okay, what is my bladder actually trying to tell me? Normally, a bladder should take about 2 to 4 hours to fill, can hold about 16 ounces of fluid. It fills really, really slowly, like 1 milliliter a minute, like a drop a minute, okay? And it doesn't like irritants. It doesn't like acidity. Things like caffeine, alcohol, spicy things, artificial sweeteners. Your bladder doesn't like those. So you may notice it's going to try to flush those out. So when you get urgency, and this is especially important in the postpartum period, because that's where I really see people getting into trouble with this, is just because you are hydrating more, but you also are just so hyper aware of that area that, you tend to go to the bathroom with every single little urge, right? And so just be mindful. What is my bladder trying to tell me? She might be telling you that it's time to go, or she might be giving you a false urge because she knows that you're going to heed every single little urge. And if you do that, then she's going to learn that she doesn't have to fill all the way. And eventually she's going to run the show. So a little mindfulness goes a long way. And on the other end, we've got our bowels. Yep, controlled by the same muscles. The deepest layer of our pelvic floor, the significant muscle there is the puborectalis. The puborectalis holds the rectum at a kink, right, at a 90-degree angle. And that is one of the mechanisms that keeps us continent of our bowel. When we get the signal, our brain gets the signal that it's time to go, puborectalis relaxes, whoop, and the path becomes straight. And we have a bowel movement, okay? I am not a paid shill for Squatty Potty Inc., but I should be because I firmly believe in that mechanism that being in the squatted position, relaxing the puborectalis muscle is the way and the light, okay? So if you want to do one good thing for yourself, You don't necessarily need to buy a squatty potty, but find a way to have bowel movements in that squatted position. Straining at the bowel is one way that people during pregnancy and in the postpartum period really get themselves in trouble, both in terms of diastasis, pelvic organ prolapse, stress incontinence, pelvic pain, and all sorts of other issues. We know that pregnancy slows down our motility in our bowels for some of us, and postpartum period can also slow down our bowel motility as well. So pushing and straining at the bowel, never a good thing to do. Squatty potty or something similar is a really easy intervention that you can implement right away. Basically, pelvic organ prolapse, we used to think is just a problem of a weak pelvic floor. It is not. It's a problem of what we call tensegrity, the tension between the muscles, the ligaments, and all the elements that are holding up the organs in the pelvis, the bladder, the uterus, and the rectum, okay? So there are many things that make up that tensegrity unit. Think about it like a suspension bridge, okay? And every little piece of that suspension bridge has to have the right length and tension in order for that bridge to maintain its structural integrity. So we have the pelvic floor on the bottom, we've got our ligaments from up top, we've got our pressures in our abdomen, okay? And all of those have to be working great in order for our organs to stay happy. Now, if our pelvic floor is weak, yeah, that's going to be a problem. If our pelvic floor is hypertonic, too tight, that's going to be a problem too. Think about during delivery with all of that pushing that has to go on. And if the pelvic floor is not relaxing and not giving, something's going to have to give, right? And what's going to give? An organ, a ligament, right? Something's got to give. And so that's where in prenatal physical therapy, we work a lot on the length and the flexibility and the motor control of the pelvic floor in order to be able to fully relax and open the perineum and the bulbocavernosus. Does that make sense? So there's a few types of pelvic organ prolapse. These are the main ones. There's more. So here's normal, happy pelvic cavity. Cystocele is basically when the bladder herniates into the front part of the vaginal wall. Rectocele, the rectum herniates and outpouches into the back wall of the vagina, and the uterine prolapse is when the uterus itself descends into the vaginal wall. Now, there are varying degrees of pelvic organ prolapse based on how far down that herniation is happening. You can have just one of these types. You can have some combination of all three. I find that most people will have some descent in the early postpartum weeks. Even if you have one right away, not to freak out because you have relaxin in your system and your ligaments are not in the shape they're going to be 6 months down the road. One important point about relaxin is that it's going to stay in your system for 6 to 12 months after you stop nursing. So, yep. Fun. So those ligaments take a long time to repair. So that's where rehab becomes so important because that's where we learn the strategies, the pressure regulation, the body mechanics to really protect that prolapse. And really, it's not going to be until a year after you stop nursing, if that's what you choose to do, that we'll really truly know if we have a prolapse or not. Does that make sense? So if at your 6-week checkup, someone tells you, oh my gosh, you've got a cystocele, don't freak out. Don't freak out. Because you may have one now, okay? But that doesn't mean that that's the way things are going to be 6 months from now, okay? There's a lot of healing that happens in that 6 months. So what can we do? These are things we can do if we have a prolapse or proactively. Focus on bowel health is the most important. The squatty potty, hydration, take your birth professional's advice on supplementation. I know a lot of the midwives around here love the CalMag supplements. I just listen to your practitioners on what's appropriate for you to maintain your bowel motility. If after birth they're recommending stool softeners, take those stool softeners. Do not let yourself get constipated, okay? That's like number one thing you can do. Learn how to breathe with your diaphragm and regulate your intra-abdominal pressure, okay? Learn how to use that core-setting motion in your abdomen when you are picking up your baby, when you are pushing open heavy doors, when you are getting in and out of bed. That motion, that drawing your core into midline is everything. And if you can learn how to do that and coordinate that with movement, you're fine. It's so simple, but it takes practice, okay? Avoid breath holding, okay? That is huge. That is called a Valsalva. Fun fact, that is named after a person. I looked it up. Antonio Valsalva. He must be so proud that he invented the maneuver. No breath holding, okay? And you do it more than you realize, okay? We do it with lifting at the bowel and during labor and delivery. And you may have to do it a time or two to generate some pressure, but just be mindful of it. And of course, an individually tailored exercise program to your body is always best. We talked about some of the common aches and pains, the low back issues having to do with the postural changes, the stress on the lumbosacral joints, the pelvic girdle pain in response to relaxin, some of the lumbar nerves that come out and are relevant to the groin area. Another common one, a common term that's thrown around a lot is sciatica. That is kind of a non-descriptive term. Basically, physicians use it to describe any pain that's going down the legs. There are a number of different things that can cause sciatica. It can be a true irritation of the sciatic nerve. Sciatic nerve comes out under a hip rotator muscle called the piriformis. And so tension in the piriformis can decrease blood flow to the sciatic nerve and make it really irritable. Lumbar discs, if they're being what we call dearranged. People hear discs and they get really scared. Don't get scared. Discs do not slip. A disc herniation is a medical emergency, and that takes thousands and thousands of faulty movements, namely bending and twisting. So your discs are extremely strong, but with some of the anatomic changes, the fluid in the discs can get dearranged and pushed backwards in the fibers of the disc itself. And so that can actually refer pain itself, the discs themselves. 90% of discs actually heal on their own. So we can work with that. Myofascial pain can cause referral all the way down the leg. So, if you have pain going down your leg, just know there's not one accepted cause for that. There are a number of different things, both in the non-pregnant body and the pregnant body that can be causing sciatica, okay? Labor and delivery, we never want to go into that experience with, a negative expectation. And so learning about various pain management techniques. I myself was a Hypnobabies user, and I loved it, absolutely loved it. Practiced positive affirmations and hypnosis every day and night for 6 months. And while I didn't use it during pushing, the sound of that lady's voice just pissed me off while I was pushing. When things changed course, hypnosis was everything. And I think that's what made my delivery actually turn out extremely positive. But there are so many different management techniques. But we know that after delivery, we're going to have some effects that persist, swelling in the cervix and the pelvic floor. Possible varicosities in the pelvic floor. You can get varicose veins in the labia, in the ovaries, in the uterus, and those themselves can be pain generators. Any ligamentous damage, tearing, those. But the good news about all of those is that tissues have a time frame for healing, and those do heal. And so we learned from Madrona last time, or at our last talk, that the fourth trimester is really the time to focus on healing and to be very kind to ourselves, because there's so much physiologic healing taking place in that time. Breastfeeding itself, we talked about our front body and some of those postural changes that can lead to overuse in some of the myofascia and, just ligamentous strain. Demands of caring for the baby. Mommy thumb, that's one I learned about. Pain in de Quervain, it's called de Quervain's tenosynovitis. Basically, it's actually a fairly common wrist issue that new moms get because of ligamentous laxity and poor body mechanics in picking up baby. So being mindful of holding our wrists in the right position. Caring for a baby is physically demanding, so, give your body some love. And chronic pelvic pain, which is a whole nother beast, and I could give a whole nother talk just on that. So basically about pain, no, it's normal and abnormal. I think with pregnancy and really any women's issue, I think we've been taught that, oh, well, you're just pregnant, just deal with it, you're gonna be in pain. Little aches and pains, your body's going through some intense structural changes, right? And especially after labor and delivery, you've been through a battle. It's normal to feel a little beat up. Intense pain that is interfering with your daily functioning, that is interfering with your mental and emotional health, that is causing you to be depressed, to avoid activities. That is not normal, and that is not something you need to deal with. So seek quality treatment early. I know at our clinic right now, I'm the only person who's doing this type of work. And so if you even think that you might want to get in during pregnancy, and this is for some of our Zoomers too, and people who are watching the video later, ask for that referral in the first trimester, because it might take you 8 weeks to get into the clinic. We'll talk about that in a little bit amongst our group about, how we might get in how we might work that a bit. But in general, seek treatment early, whether it's physical therapy, whether it's, any type of quality body work with somebody who is experienced with pregnant bodies. Whatever you do, just don't wait till it gets bad. Get ahead of it. And move your body in whatever way feels supportive. And it doesn't necessarily mean that now's the time to, take up new hobbies or new forms of exercise, but movement is key. And we need to address other factors that contribute to pain. Mental health is the huge one. That is a huge, huge issue for me. We are actually blessed here in Taos to have so many wonderful mental health professionals. And now in the age of COVID, one blessing has been telehealth. So there are many in-network professionals here in Taos. So if we have insurance, we actually have some very good in-network folks over at Golden Willow, Taos Behavioral Health. And there are services here available. And I think mental health is one of the big issues that contributes to pain. Diet, which we're going to learn about at our next meeting, and just taking care of our overall general health. So, and lastly, getting back to exercise. The ACOG, the American Gynecological Association guidelines are garbage. They're basically like whenever. Some people can go back to exercise in 2 weeks. Some people take 6 months. It's like, okay, wonderful. The prevailing wisdom is 6 weeks. 6 weeks postpartum. This magical switch flips and you are healed and you may go back to exercise. And it's like, okay, what does that mean? And so most people feel pretty lost with that. So the various factors, so it's going to be different for everybody, right? And there's a lot of factors to consider. Number one is going to be our mode of delivery. With vaginal deliveries, did we have an uncomplicated vaginal delivery? Did we have any tearing and stitches that are healing? Did we have a vacuum assisted or an instrument assisted delivery that might mean we have bruising or things that need to continue healing a little bit? Or did we have those factors and we're feeling fine, Did we have a cesarean delivery, in which case 8 weeks is going to be more the standard of doing anything, with your core or any type of physical exertion. So you're going to really want to listen to your physicians, especially in the case of cesarean delivery. We're going to want to respect the normal healing process. Every injury has a physiology. 6 to 8 weeks is a typical physiologic healing time for most injuries, but we know that every body's going to be a little bit different, and there are a lot of things that affect each person's individual healing time. So you know your body best, and so you're going to need to really know how are you feeling? How are you healing? Do you feel like some of these things that have happened during pregnancy, during labor and delivery are healed, or do you need more time? Don't feel like at 6 weeks, like, haha, you're healed. I don't know. I'm reading a text about that right now, and they keep referencing this 6 weeks, and I just want to scream. So anyway, so we have to take into account some of the physiology. Swelling can take quite a long time to resolve, especially if you've had IV fluids in the hospital. Relaxin, again, is going to be with you for 6 to 12 months after you stop nursing. That doesn't mean you can't do high-impact activities. That just means you need to be respectful of the fact that your joints are going to be more loosey-goosey for quite a while, okay? Various musculoskeletal problems that were there pre-pregnancy, that developed during pregnancy, those aren't just going to magically go away. Well, most of them. Some of them will. But we still need to be respectful. And then diastasis recti, that doming, that corsetting. In general, we want to, if we have diastasis, we want to avoid just strict sit-ups. We want to avoid activities that are going to encourage us to hold our breath, okay? If basically any activity that is going to cause our belly to puff out, then that's too much for us. That's too heavy for us. We want to be able to corset our belly in, use good body mechanics. And if we can't, if we're tending to hold our breath or puff our belly out, then it's too much for us at that moment. And that's where guided direction can be really, really helpful. And then we also have to keep in mind our goals. Okay, what are our goals? Is it to get back to some of the more vigorous pursuits? I've got folks who want to get back to running a marathon, climbing Wheeler Peak before the end of the summer, and some people have done that with great ease. Some people weren't exercisers before and want to get into exercise. Some people just want to push their baby in a stroller and feel good about it, okay? Repairing a diastasis is a big one, and that is definitely, I can't say that we can repair every single diastasis, but we can give strategies to really set up a really nice healing environment for that connective tissue. And then we have to consider what your prior level of activity was too. If a patient who is working out quite a bit during pregnancy is going to most likely have an easier time jumping right back in than someone who was sedentary previously during pregnancy. So, it's very individual. General principles: low and slow, respect the recovery time, assess your response, stay hydrated, and if you're nursing and exercise seems to have an effect on your lactation output, then you might have overdone it, because exercise burns calories, right? And what does lactation require? Calories. So, that doesn't mean don't exercise, but you might have to increase your caloric intake if you're going to start burning a lot more calories with your physical activity. And that's something that a lactation consultant can really help you with too. That is not my area of expertise, but something to be mindful of. Signs you overdid it. Increase in bleeding. You will be passing lochia postpartum. 6 weeks is the norm that's quoted in the literature. Anything past weeks is considered postpartum hemorrhage. Again, I question that number. But if working out causes an increase in lochia, then that may be a sign, or, increased clotting or just, abnormal discharge, then that may be a sign that we overdid it. Sharp pain. Most of us who are very active are kind of craving that hurt so good soreness, but If it's causing sharp pain, yeah, no go. Excessive soreness. Yeah, most of us, again, want to hurt so good, but if we can't walk afterwards, yeah, we might want to dial it back. And if we're noticing any incontinence of urine, stool, or even gas incontinence is a thing too. So basically we can't hold things in that we used to be able to hold in. And a word about running. I could go on about this for a while too. This is not a bash on running, but only to show that, for every action there is an equal and opposite reaction. The ground reaction force that is transmitted up the chain with running can be several times your body weight. So knowing that you have relaxin in your system, the ligaments of your pelvic organs are stretchy and vulnerable. There is a lot of prehab to getting back to running. And a guided back to running program can be really helpful. There's that doming I was talking about, and it can be intense and severe, or it can be little. That's a really severe case of doming right there. But we talked about that, avoiding things that will cause that doming. Some people say excessive trunk rotation, the theory being that the obliques can pull on the rectus. With rehab, you can get back to bicycle sit-ups, stuff like that, but right off the bat, it's probably a good idea to avoid those until you can confidently do that and control the diastasis. And it's never what you do, but how you do it. And my very last point, you guys have made it through a long presentation, the myths surrounding Kegels. Kegels are the bane of my existence. So people say, oh, you're a pelvic floor therapist, so you just teach people how to do Kegels, right? No, I don't. So number one myth about Kegels is that they are the best way to strengthen the pelvic floor. So Kegels were the first time that female pelvic health was ever mentioned in any scientific literature in the 1950s by Dr. Kegel himself. And God bless him for actually taking a look at female pelvic health. However, and that was probably the last time anyone looked at female pelvic health for quite a while in the literature too. So he described this exercise of squeezing, releasing, and that became the dominant mode of pelvic floor exercise. What we have found recently through studies that were conducted in a similar way to the original Kegel studies is that, number one, Kegels are not the best way to strengthen your pelvic floor. So if you come to see me in clinic, Kegels might be the very, very last thing I teach you to do, if at all. Because recent studies have shown that upright functional exercise is actually way better for the pelvic floor, can get much stronger contraction through the pelvic floor, and produces much better sustained, much more meaningful strength gains and functional gains over time. Things like lunges, squats, things that we like to do, things that allow us to do these things in our daily life, like get up and down off the floor and play with our kids, do some of our more vigorous pursuits. Those are actually better for your pelvic floor, and if you learn how to do them with good body mechanics, they will actually give you a stronger and more functional pelvic floor. Number two, that you should practice Kegels by stopping the flow of urine. Wrong. That is a great way to give yourself a urinary tract infection, number one. Number two, messes with that reflex, so your bladder over time will stop listening to your pelvic floor and can lead to issues with urge incontinence. It's a fine test every once in a while if you want to see if you're squeezing the right muscles, but as an exercise, no, do not sit there and go, okay, I'm doing my Kegels, start, stop. No, not good. Number three, you should be doing, insert arbitrary number of Kegels a day here. Every 6 months or so, Goop comes out with an article that we should be doing 100 Kegels a day, we should be doing 50 Kegels a day. It's different every time, I swear. I have a Google alert, actually, and it's different every time. Should we be doing Kegels at all? It's very much individualized. If we have an overactive pelvic floor, pelvic floor muscles are too tight and tense. That can actually make our issues worse. So some people should not be doing Kegels at all. If we have an underactive pelvic floor, it really just depends on what gains we're trying to make, and is that the most effective way to strengthen our pelvic floor? It just varies way too much person to person. And number 4, pelvic floor physical therapy is just about doing Kegels. I hope if if you've gotten anything from this that it's not. So when to see a pelvic health PT? So prenatally, I like to see, ideally, I would see folks starting in the 2nd trimester. And so usually my referrals come because of pain. People are having hip pain, back pain. Sometimes people come for urinary incontinence issues or bowel problems. But mostly pain is the big referral that our folks here send for. Ideally, folks will ask for a referral even if there are no issues for a prenatal pelvic floor assessment. It is really a lot easier to rehab a pelvic floor if I know what it was like going into labor and delivery. No one goes into labor and delivery with one type of pelvic floor and comes out with a radically different one, okay? You go into labor and delivery and come out with the same pelvic floor. Okay, it's just seen some stuff afterwards, okay? So getting a baseline assessment is very, very helpful so that we can really hit the ground running later. And then I do a lot of labor and delivery education, perineal massage techniques, push education, stuff like that. So it can be really fun. It can be really fun. So, coming in, even if you're not having a specific complaint. Postpartum, I typically wait until some of that physiologic healing has taken place, 6 to 8 weeks. I've had people come in sooner. The soonest I've seen someone is 2 days because she was having just horrendous pain from a hip injury she sustained during labor with her legs up in that horrible dorsal lithotomy position. That was the outlier. Usually it's a few weeks, 6 weeks if we're going to do any internal pelvic floor assessment. And so a lot of folks want a postpartum pelvic floor assessment. We check for muscle strength, scar tissue, pelvic organ prolapse, diastasis. I do visceral manipulation. Basically, we take for granted that the organs get shoved up into your rib cage and then they all just get flopped back down into their positions. So a little bit of abdominal work can be really helpful. And individualized rehab. What do we want to get back to? What are your issues that are presenting for you? So that's it. That's what we got. Thank you.